Good evening, sir. I'm Dr. Teena from SIMS. First, I'm going to talk about Remimazolam. Remimazolam is an ultra-short-acting benzodiazepine. Remimazolam diazolate. It is a water-soluble, ultra-short-acting benzodiazepine. The parent component of remimazolam is midazolam. It has the pharmacokinetic properties of both midazolam and remifentanil. Preparation, introduction of carboxylic ester linkage into the structure of benzodiazepine core makes the drug suitable for metabolism by non-specific tissue esterases like remifentanil. It leads to faster onset and offset of sedation, shorter duration of action, organ-independent elimination, and has an advantage of availability of a reversal agent. Mechanism of action, it interacts with the site located between the alpha and gamma subunits of GABA receptors and has the greater frequency of channel openings, resulting in increased chloride conductance and hyperpolarization of postsynaptic neurons. Thus, the postsynaptic neurons are resistant to excitation, and thus it produces anxiolysis, sedation, anterograde amnesia, anticonvulsant, and skeletal muscle relaxant effect. Pharmacokinetic effect of remimazolam. The onset of action is 1 to 3 minutes. Peak action for remimazolam is 4 minutes, and its duration of action is around 10 minutes. The pharmacokinetic of remimazolam 0.01 to 0.3 mg per kg administered over 1 minute, compared with the midazolam 0.075 mg per kg administered over 1 minute. The volume of distribution for remimazolam administered at this dose was 34.8 liters, whereas that of midazolam was 81.8 liters. It has the elimination and clearance of remimazolam was 3 times that of the midazolam, that is 70.3 versus 23.02 for midazolam. The T-half of remimazolam is around 70 minutes. So it has a smaller volume of distribution and slower clearance rate. Remimazolam is rapidly metabolized by the tissue esterases to inactive carboxy acid metabolite. So it is predominantly excreted in the urine. 80% of the dose was detected in the urine as a metabolite, and 1% was detected as an unchanged drug. Plasma protein binding of remimazolam is around 92% with serum albumin. The contact sensitive half-life of remimazolam is around 7.5 minutes. That is, the offset of remimazolam effect after the cessation of infusion was 7.5 minutes. It can be given in elderly, renal, and hepatic impairment patient as it is as it has an organ independent elimination. Uses of remimazolam. Remimazolam for procedural sedation. It can be used for diagnostic and therapeutic procedures because of its faster onset of action and recovery. It has an inactive metabolite, so it has minimal residual effects. The dosage for procedural sedation is 5 mg over 1 minute for induction and 2.5 mg over 15 seconds with more than or equal to 2 minutes between the doses that can be given. For AC grade 3 and 4 patient, the induction dose is around 2.5 to 5 mg and top-up doses 1.25 to 2.5 mg. It may lead to hypoxia, bradycardia, and hypotension. Remimazolam for general anesthesia. For pre-medication, it can be given in the dose of 0.075 mg per kg. For induction, 0.1 to 0.3 mg per kg, and for maintenance, 0.72 to 3 mg per kg per hour. It can be used as a hypnotic component of total intravenous anesthesia. 6 to 12 mg per kg per hour IV infusion was administered for induction, followed by 1 mg per kg per hour for maintenance dose. ICU sedation. ICU patients are critically ill with essential organ failure like liver or renal, so it can be used because of its metabolism is independent of liver or kidney. Flumazenil reversal. So the hypnotic effect of the remimazolam was reversed by using flumazenil. It is the antagonistic of positive allosteric modulator effect of benzodiazepine. The reversible dose of flumazenil is 0.2 mg as an initial dose over 15 seconds. 0.2 mg can be repeated after 60 seconds up to a maximum of 4 additional times to a maximum dose of 1 mg. The flumazenil has a half-life of 40 to 80 minutes. Adverse effects of remimazolam. It may lead to hypotension, headache, nausea, vomiting. Solubility of the remimazolam decreases at a pH of more than 4, so it should not be dissolved in an alkaline solution. It also should not be dissolved using ringer lactate or acetate as it forms precipitates with remimazolam. That's all about remimazolam, sir. I'm going
to
once
again, before you go to the Fospropofol, why it is called remimazolam?
It has the properties of both midazolam and remifentanil, sir.
Very good. What is the property of remifentanil this drug exhibits?
Remifentanil was manufactured by tissue-specific essences, sir. So it has the property of that.
Very good. And what is the, is it, it is called soft drug sometimes. Why it is called soft drug?
Yeah, sir. It is.
Any idea?
I read about that, sir.
Forgotten.
Yes, sir.
So soft drugs are drugs which, when they are metabolized, their metabolic products do not have any effect clinically. Then they are called soft drugs. Okay.
Yes, sir.
Whereas prodrugs are drugs which by themselves do not have any action, which you are going to see in the Fospropofol. It is a prodrug. It has to be converted to propofol to execute its actions. So prodrugs are drugs which per se by their own chemical nature do not have any significant clinical action or pharmacological effects, but they are converted into an active component which will become which execute their or exhibit their pharmacological activities. Whereas remimazolam is called a soft drug because the drug by itself, the chemical composition nature of the drug itself produces the desired effect, but the metabolite of the drug is an innocuous one, which will be simply excreted, does not have the same effect as the parent compound. Okay, that point alone you have to add to this answer. Okay, now you can go to the next topic.
Yes, sir. Fospropofol. Fospropofol is the water-soluble prodrug of propofol. Fospropofol disodium. The structure of fospropofol disodium is phosphano O-methyl 2,6 diisopropyl phenol plus disodium salt. When a substitution of hydroxyl group by phosphate groups creates an electronegativity in the propofol structure, which causes the drugs to dissolve readily in water. So it does not contain lipids, egg products, or preservatives. So it eliminates the allergic, bacterial infections, and hyperlipidemic concerns of propofol. A mechanism of action: propofol is converted into propofol by endothelial alkaline phosphatase. So this propofol has an agonistic action on the GABA A receptors, and it increases the chloride conductance and hyperpolarization, and it inhibits the postsynaptic neuron. It also inhibits the excitatory NMDA glutamate receptors and decreases the calcium entry into the cells and causes postsynaptic inhibition. So it has a delayed onset and delayed clinical effect. It can be administered intravenously. 1.86 mg of propofol is equal to 1 mg of propofol. It has a time-dependent enzymatic conversion, so it releases the active drug slowly. The onset of sedation is around 4 to 8 minutes. There's a dose-dependent effect, like if 6 mg per kg of fospropofol was given, the drug peak action was at 4 minutes. The peak plasma concentration of propofol was at 12 minutes. 18 mg per kg was given. The peak plasma concentration was at 8 minutes. The induction dose is around 6.5 mg per kg for IV bolus and 1 mg per kg for maintenance. The volume of distribution for propofol is 0.33 plus or minus 0.069 per liter per kg. And for propofol, it is 5.8 liters per kg. The plasma half-life of fospropofol is 0.88 hours, and the total body clearance is around 0.36 liter per kg per hour. It has an extensive protein binding of up to 98%. Metabolism: the fospropofol is converted into propofol by alkaline phosphatase present in the endothelium and liver. This propofol is then converted into propofol glucuronate, phosphate, and formaldehyde. The formaldehyde is then converted into formic acid by glutathione dependent and independent dehydrogenases present in the liver and erythrocytes. This formic acid is oxidized to carbon dioxide and eliminates the excess formate through tetrahydrofolate pathway. The serum phosphate, which is produced by fospropofol, is excreted through kidneys. It has a renal elimination of around 0.02%. Uses of fospropofol. Fospropofol can be used as an IV sedative hypnotic for monitored anesthesia care and diagnostic procedures like bronchoscopy, colonoscopy. It can be used for minor surgical procedures like arthroscopy and osteotomies. Adverse effect: it is less painful. Adverse effects of fospropofol: it causes transient paresthesias and pruritus because of the phosphate ester present in its structure. It may also causes cough, nausea, and vomiting. Because of its sedative action, it causes hypoxia, respiratory depression, or apnea. For that, we can give supplemental oxygen. or airway assistant maneuvers like tactile verbal stimulation, jaw thrust, chin lift, and manual ventilation if needed. It may also lead to hypotension. It can be managed accordingly. The advantages of Fospropofol over Propofol. So Propofol, it is present in an emulsion form, and Fospropofol, it is in aqueous form. And the aqueous solubility of Propofol is low, and the Fospropofol, it is high. The dose of Propofol is around 1 to 10 mg per kg, and Fospropofol, it is 6.5 mg per kg. Onset of action of Propofol is faster, like it is 40 seconds to 1 minute for Propofol and 4 to 8 minutes for Fospropofol. The duration of action as a single bolus dose is 3 to 10 minutes for Propofol and 5 to 18 minutes for Fospropofol. Half-life of Propofol is around 1.5 to 11 hours, and Fospropofol, it is 48 minutes to 48 minutes. Elimination is more than 1% is excreted in urine for Propofol, and 0.002% of drug is excreted unchanged in urine for Fospropofol. Indication for Propofol is the induction and maintenance of general anesthesia, short-term procedural sedation of mechanically ventilated patients. For Fospropofol, it is MAC sedation, diagnostic procedures, and therapeutic procedures. Solubilizing agents like soybean oil and egg lecithin are present in the propofol, which may lead to allergic reactions, bacterial growth, hyperlipidemia, and pain on injection. It is absent in Fospropofol. Paresthesias and pruritus are absent in propofol emulsion. It is present in Fospropofol. Propofol may sometimes lead to cardiorespiratory depression, bradycardia convulsion. Fospropofol has less side effects when compared to propofol. And that's all.
Did you mention about injection pain?
Yes, sir. Like injection pain is more on propofol, sir. It is less in Fospropofol.
That is considered as one of the biggest advantages and the reason for manufacturing and marketing this drug, Fospropofol. Because one of the common practical disadvantages of propofol is even every day you all would come across patients complaining of severe pain, which we try to attenuate with pre-treatment with or mixing it with lignocaine. But in spite of that, patients do complain of pain, which is supposed to be totally absent with this. So all pharmacology questions you have to mention about the first chemical nature of the drug, what group it belongs to, then what is its mode of action and what are all the systems it acts on. Then you write about the pharmacokinetics and pharmacodynamics, and then how the drug is eliminated, what are all the various doses and the indications, contraindications, advantages and disadvantages. So that under those topics, if you write, you will be able to complete all the pharmacology questions that are asked in your examination. So he has nicely covered all the points. Anyway, I'll just share my PPT to